Welcome everybody to July 2021 Bench Talk Live from the Kentucky Academy of Science. This is Amanda Fuller. I'm the Executive Director of the Kentucky Academy of Science, and this is our monthly public program. We are Kentucky Scientific Society. Our mission is fostering scientific discovery and understanding in Kentucky, and this is one of the more fun ways that we do that is by bringing scientists together every month to share science with each other and share it with the public. All the programs are on our website at kyscience.org, so you can check out the great programs that we've had for more than a year now every month and share those with friends and colleagues. I have a trash truck outside my window if anybody can hear that right now. Yes, we're still working from home. So Kentucky Academy of Science has a number of other programs that you might want to check out. We have a speakers bureau, so you can request a speaker on a variety of different topics. We have a couple hundred people in there right now, I think, who are willing to speak to civic groups, government, any sorts of events that you have that you would like a scientist, we have them for you. We have grants for our members, small research grants. We have a Science Education and Outreach Award that we present to a member every year for that wonderful work. And we have an annual meeting that'll be coming up in November at Eastern Kentucky University, November 5th and 6th. So hope to see you all there. We're looking forward to being in person again at Eastern Kentucky University. Bench Talk Live is going to take August off. And then in September, we'll be back with a program from Murray State University about the hemp research program at Murray. They've been doing that for a few years now, and I'm excited to hear from them about what they've learned about growing hemp in Kentucky. And I also want to give a shout out to part of the inspiration for the series was from Bench Talk, The Week in Science, which is a weekly radio show and podcast. And Dave Robinson produces that show. And Dave, I'll give you just a minute to share a little bit about it and point people to where to find it.
Yeah, if you live in Louisville, turn your radio dial to 106.5 FM, but you can also hear it live at forwardradio.org. Just Google search forwardradio.org and you'll get it. Bench Talk, The Week in Science, we come on a half hour a week, and basically we're a clearinghouse for current research that's going on in natural sciences, social sciences, STEM education, science policy, and so check us out. This week, our show is about telomere research that's being done here in Kentucky. A couple undergrad students presented that, and then got a story on the physics of cooking, and then it ends with a poem. And so every week, you'd never quite know what kind of science topic we're going to cover.
It is a delightful mishmash of science, and some of the presentations from this series also make their way onto the radio show and the podcast. So sometimes we get to hear them again there, and it's a great addition to the show as well. So with that, I am going to turn it over to Mahavir Singh to introduce our first speaker. And the last thing I will say is for people during the presentations, if you have a question, feel free to pop it in the chat. We'll have Q&A after each presentation. Go ahead.
Hi, everyone. Thank you, Amanda. It's good to have you all with us this evening. As you might have noticed that we are having two exciting presentations from the experts today. Me and my executive team members of the American Physiological Society, Kentucky chapter, are welcoming you and thanking you all for joining us this live bench talk. To make this live talk happen, the credit goes to Amanda Fuller, who is the executive director of the Kentucky Academy of Science, and our vice president of the Kentucky chapter of the American Physiological Society, Dr. Scott Vicker. He's a Jefferson Fellow and the current chair at the School of Science, Technology, Engineering in the Kentucky State University, Frankfurt. A brief introduction about Dr. Harpal Sandhu. On behalf of the American Physiological Society, I'm excited to introduce Dr. Sandhu, who is joining us today from the West Coast in Portland. Hi, Harpal. After graduating from Harvard Medical School, Dr. Sandhu joined Massachusetts in Boston for his residency, and later on, he went on to UPenn for his fellowship. His expertise are in retinal inflammation, and lately he also ventured into the role of artificial intelligence in medicine. So today, he is planning to tell us about a range of eye conditions that are associated with COVID-19 infection as well as the COVID-19 vaccines. Now over to Dr. Sandhu.
Great, thank you, Mahavir, and for that generous introduction, and thank you, Amanda. Thanks to both of you for organizing this. Let me just share my screen here. Can everyone see my title page? Great. So it's a pleasure to be here. I'm sad to have left Kentucky. I was at U of L for 4.5 years in the Department of Ophthalmology and Visual Sciences, and still nominally a part-time faculty member through the Speed School of Engineering, where I still have a number of collaborations there and in my old department in ophthalmology and visual sciences. So it's a pleasure to be here. I hope this talk is not overly clinical. We'll get to the goals of the talk in a moment, but the focus of this talk is ocular manifestations of coronavirus disease 2019. So essentially the effects on the eye, as well as the visual pathways posterior to the eye. So goals of this talk. I want to review the range of ocular findings or ophthalmologic manifestations of COVID-19, discuss the putative mechanisms of these various diseases and the strength of the relationship to COVID-19 infection. Some of these may be more coincidental associations, and I think others are much closer to truer associations. And finally, if there's time, and hopefully time allows, I do want to cover ocular diseases that have been temporally associated with the different COVID-19 vaccines, again, with the same kind of goals of assessing to what extent they may truly represent a causal relationship rather than a mere association. So ocular manifestations by anatomy. I mean, I'm keenly aware this is a mix of physicians and probably more basic scientists. But if you think about the eye from the front of the eye anteriorly, the surface of the eye, and moving posteriorly into the eye through the optic nerve, and then back to the brain, that's essentially how I'm going to organize the manifestation. So starting with the surface, then the anterior segment of the eye, so that's from the lens through to the cornea, then the posterior segment, that's basically everything behind the lens. So the vitreous, the retina, the choroid, back to the optic nerve, and neuroophthalmic, which is really everything from the optic nerve head, so the optic disc where the optic nerve inserts onto the eye, back posteriorly to the optic chiasm in the brain, and then the visual pathways back to the occipital lobes. And yes, believe it or not, there has been pathology described in every single one of these different compartments. Though, as I have been alluding to, the strength of the true causal association we'll discuss as we go along. So this was a paper in JAMA Ophthalmology that came out in, I believe it was February of 2020. And this was the paper that really put all of ophthalmology in the United States on alert as to COVID-19 and its relationship to the eyes, as well as just the existence of the virus on the surface of the eye. So this was, I won't belabor the points. I have a lot of the key points of the actual paper here on the right-hand side as bullet points. But essentially, there were a number of patients described from China where a third of them who were COVID positive patients had signs of some kind of ocular surface involvement. And some of them were non-specific signs. Chemosis is swelling of the conjunctiva. Some of them had tearing, some of them had redness in the eyes. But what was particularly striking, I mean, almost shocking at the time, because this was really before the first wave hit in the United States, was that about 5% of these patients had SARS-CoV-2 recovered from the surface of the eye. And so this was when we really became on alert that there may be a possibility of transmission through ocular secretions, and that conjunctivitis might even be a presenting sign of the disease. And it can go both ways. You can have patients who are COVID positive who have non-specific ocular involvement, say redness and tearing, but don't actually have PCR positive virus or recoverable virus from the surface of the eye. But you can have the reverse too. You can also have patients who don't look like they have much in the way of eye involvement, but actually they do have SARS-CoV-2 recoverable from the surface of the eye. So this was really quite a shocking paper when it came out. And this put us on alert to really think about the eyes and the perhaps direct infection of the surface of the eye, and even potentially the eye as a conduit for infection into the body. You know, we've sort of learned now that it's really not a major route. Respiratory is really the major route. But this really put all of America's ophthalmologists on alert, and eye community. But this represented a clear ocular manifestation that was causally related to the virus, and in this case represented direct infection of the conjunctiva in the cases of conjunctivitis. So now moving posteriorly through the eye, so you know, a number of cases of uveitis, anterior uveitis. So this is inflammation inside the anterior chamber of the eye, inflammation of the iris, or that's the colored part of the eye, of course, around which the pupil is formed, or within which the pupil is formed, I should say. And we began to see cases from really one of the Western countries, developed countries that was hardest hit early on, from Italy, of a number of different cases of anterior uveitis associated with COVID infection. So this one particular case from Northern Italy involved a patient who, are you able to see my cursor here? Are people able to see that? Great, terrific. So this was a patient who had a conjunctivitis, who was COVID-19 positive, had a conjunctivitis, had inflammation of the conjunctiva. This is the conjunctiva in the undersurface of the eyelid. I know those of you who are not ophthalmologists are not used to looking at this, not used to flipping people's eyelids like a kindergarten student. But this patient, in addition to having conjunctivitis, also had inflammatory precipitates on the anterior lens capsule and neovascularization, or at the very least, some kind of a vasculitis of the iris where the iris vessels were engorged and inflamed. And this patient was treated with topical drops that we don't typically use in the United States, chloramphenicol and betamethasone. But ultimately they improved with the use of topical steroids and topical antimicrobials. There was complete resolution of this sort of inflammation. You know, this was a somewhat weak case, though, to be perfectly honest, because PCR was not performed on the aqueous humor. We didn't see, normally, one of the beautiful things about ophthalmology is our ability to literally visualize inflammation. We can see white cells percolating inside the eye. And that wasn't the case in this example. And then finally, and this has plagued. Now, since this first case, there have been many more cases of uveitis that have been reported. What's really plagued our ability to understand this is it's just unclear whether the inflammation we're seeing in the eye that's associated with COVID-19 infection represents actual active virus inside the eye versus a sterile immune response for some other reason, like a molecular mimicry and responding to SARS-CoV-2 antigens, but in a sterile fashion. So that is still an open question. However, quite clearly, SARS-CoV-2 can cause multiple different forms of uveitis. So let's talk more about that and continue to move posteriorly through the eye. I imagine all of you at this point have heard about multi-system inflammatory syndrome in children, MISC, caused by COVID-19. It's strikingly similar to Kawasaki's disease, which has long been thought to be essentially a post-viral or post-infectious inflammatory syndrome in children, potentially deadly because it can cause coronary artery aneurysms, amongst other things. But Kawasaki's has classically had eye involvement, certainly not in all cases, but in many cases, conjunctivitis, episcleritis, scleritis, and indeed uveitis, usually anterior uveitis. And sure enough, with MISC, we've now seen many cases of anterior uveitis, not to nearly the same extent as Kawasaki. I mean, there do seem to be distinctions between Kawasaki and MISC. You know, a pediatrician would be better able to elaborate on that. It's not nearly as common eye involvement as it is in Kawasaki's, but quite clearly there's eye involvement. There can be eye involvement in MISC, which is an idiosyncratic systemic inflammatory response to SARS-CoV-2 infection in children. That's still not that well understood, unfortunately. Okay, let's continue to move backwards. So the posterior segment of the eye. So specifically, the reticulized layer beneath the retina. And really, you can broadly divide these manifestations into two areas, essentially vascular diseases and inflammatory or autoimmune diseases. And the vascular diseases are predominantly two different things. They're either retinal venous occlusions. So vascular occlusions, they can be arterial, but much more so on the venous side, much as we've seen systemically with COVID-19 infection, with patients getting pulmonary embolisms. And then the second broad category would be essentially non-specific microvascular findings in the retina, which I'll discuss in a moment. That second bullet point represents two very rare syndromes of arteriolar occlusion in the central retina, which we call the macula, of course, in the deep and middle layers of the retina, respectively. And they're called acute macular neuroretinopathy and paracentral acute middle maculopathy. Don't let the terms fool you. We don't actually know that much about these diseases, despite the lengthy names. In fact, in retinology, the longer the name of the disease, the less we tend to know about it, because we're just describing morphology. I think I see some people in the audience nodding their heads, but that happens in neurology as well, and others. And then the autoimmune diseases I'll get into as well, basically manifestations of uveitis. So retinal vein occlusion. So there have been, initially there was a small number of reports, but increasingly more of retinal vein occlusions in young, otherwise healthy patients with COVID-19. And for some context, for those of you who aren't that familiar with this condition, actually Mahavir does quite a bit of research on retinal vascular disease, including retinal vein occlusion. But this is usually a disease of late middle age and the elderly related to arteriosclerosis. Basically, it's a disease of people who are vasculopaths, people with hypertension and hyperlipidemia to some extent, but certainly hypertension and diabetes. And the veins that share a common adventitia with arteries, that adventitia can become increasingly narrowed in hypertension. Well, I misspoke. It's not so much the adventitia, it's actually the arteriosclerosis of the arteriole, and within the common adventitia that compresses the vein, and you can get a venous occlusion. And even though that occlusion opens up, it causes downstream problems, including a massive upregulation of vascular endothelial growth factor in the eye. And you end up with really dramatic fundus appearance. I mean, incredibly dramatic. You can have 4 quadrants of dense intraretinal hemorrhages. macular edema. This is an optical coherence tomography scan of the macula. And this is much closer to a normal macula. This is a macula that's highly edematous with intraretinal fluid, that's these black spaces, and subretinal fluid, that's this black space here. And this is a fluorescein angiogram, which shows fluorescein passing through the arteries and veins within the retina. And there's massive leakage of dye showing incompetence of the blood vessels, inflammation of the optic nerve, and capillary non-perfusion, which is quite typical of a severe vein occlusion. But this is not normal in anyone under 45 at all, and always prompts a hypercoagulable and sometimes even rheumatologic workup for vasculitides and other inflammatory diseases. In this one particular case, these retinal specialists in India actually treated this patient both with anti-VEGF inhibitors, ranibizumab, as well as with corticosteroids. And their initial thinking was, this was early in the pandemic, that maybe this represented a phlebitis, so a retinal vasculitis of the venous side of the retinal vasculature. But to be perfectly honest, what we've found in the time since is that that's not really the case with these RVOs related to COVID-19. It seems to be more the vascular damage, the endotheliopathy that is inherent in severe COVID-19 disease that's leading to endothelial damage and a predisposition to occlusion, particularly on the venous side, related to ACE2 being the receptor for SARS-CoV-2, loss of regulation of the vasculature, damage of the endothelium, and so on, and this cascade of vascular events that can happen. So we've really stopped using steroids in these patients. And this is still rare. I mean, this is a rare thing, even in someone with severe COVID-19 infection. But really, we're just treating these patients as typical RVO patients and treating them with antivascular endothelial growth factor. And let's continue here. Now, the nonspecific retinopathy, so there was a physician investigator in Italy, also a uveitis specialist, who, again, Italy being one of the developed countries to really be hit early on, collected a really large sample of patients, large within the retina community, of COVID-19 patients, who was able to get into the clinic, take fundus photos, optical coherence tomography, and he found pretty high rates of signs of vascular abnormalities in the retina. So almost 10% had cotton wool spots, about 10% had some kind of retinal hemorrhage. A number of them had abnormal vasculature. The problem with this is that these are really nonspecific signs. And patients who are becoming sick with COVID and are ending up as inpatients, particularly in Italy, which has a fairly old population skewed towards the elderly, is that these patients tend to have vascular disease at baseline. They tend to be hypertensive, they tend to be diabetics. So it's hard to know to what extent are we truly seeing a COVID-19 retinopathy, vasculopathy in the retina versus just the contributions of hypertension and diabetes. So still an open question, still being explored by the retina community. Now I'm mindful of the time. So how much time, Amanda, would you say I have? Another 5 or 6 minutes, maybe?
I forgot to look at what time it was when you started, actually. So
okay.
I just was looking at the clock as well. I know we did start late.
Okay. I think maybe I've been going for about 20 minutes, but let me keep going, because I certainly want to get to neuro-ophthalmic manifestations. And I didn't think we would likely have time for some of the vaccine-associated ocular manifestations. They're extremely rare, but I'd like to at least make it through neuro-ophthalmic disease, and that may dovetail to some extent with our next talk. And because of the rarity of AMN, and PAM, I think we can skip through this, but I'll suffice it to say that these are very tiny occlusions of very small arterioles in the posterior retina, usually associated with the diseases like preeclampsia, sickle cell, other things that cause vasoconstriction. And we have seen this quite clearly in COVID-19 patients. So we do think that COVID-19 can also cause vascular occlusions on the arterial side. in the retina, much as it does in the brain. So not really surprising because the two often mimic one another. We'll skip through that. Okay, so there have been several cases of uveitis involving the posterior segment around the time of COVID-19. And I'll be honest, I'm just going to load up all these images. I'm quite suspicious of most of them, with the exception of the last case. So each of these rows here is a different case, and they're essentially cases of different forms of posterior uveitis. And I'll let people read through this at their leisure, and I can certainly provide the slides. But, you know, a number of them are quite suspicious for being spurious correlations because they involve people who were having a flare of their uveitis, were treated with high-dose systemic corticosteroids, and then came down with COVID-19, which in the middle of a pandemic, if you're profoundly immunosuppressed, even temporarily, it's going to predispose you to a whole range of infections. And we know that doses of prednisone greater than 10 and certainly greater than 20 do predispose people to COVID-19 infection. That's the first case. The second case is someone who got COVID and reactivated an old case of posterior uveitis, something we call serpiginous choroiditis. This is a nice picture of active serpiginous. But the final case, which was actually given to me from a colleague in Indiana University, was a 16-year-old girl with a mild COVID infection. A month later, she developed new floaters and a mild decrease in vision in both eyes. And lo and behold, she ended up with a profound frosted branch angiitis in both eyes. And that one I actually find quite convincing. Frosted branch angiitis is a disease that was originally identified in Japan, presumed to be post-viral, mostly in teenagers, where there's profound inflammation of the retinal arteries. And it's generally treated with high-dose corticosteroids and has reasonably good outcomes, though not always. And this was strikingly similar to the original descriptions of frosted branch angiitis from Japan in the 70s and 80s, which is presumed to be post-viral. So it really does seem like COVID-19 can cause a retinal vasculitis, which, given the mechanisms we've seen around COVID, and it's both the endothelial damage, but then also separately a predisposition to inflammatory syndromes, I think is not surprising. So I actually think that that one is relatively convincing. And there have been further cases of retinal vasculitis that have been identified since. And, you know, I've already mentioned these points, but I just want to jump to the third bullet point. We always have to bring a critical eye to any of these things that are case reports or even case series, because remember, we're living in a true pandemic. More than 10% of the United States has now been infected with SARS-CoV-2. So is every medical finding that we see within a few months of a COVID infection related to the infection? You know, whatever happened to what my old internal medicine attendings used to call true, unrelated. And I know they use that term in neurology too, I think from time to time also. So we have to bring a critical eye to these things and think about pathophysiology as well as evidence and not just temporal correlation, of course. I think I should really wrap it up, but I do want to mention there have been a number of cases of optic neuritis that have been described in COVID-19 inpatients. In particular, several have been of the much more aggressive and rarer variety called MOG disease, anti-myelin oligodendrocyte glycoprotein disease, a rare form of optic neuritis. You know, I think there are more questions than answers when it comes to whether COVID-19 can really cause optic neuritis or optic perineuritis. A lot of these could be chance associations. On the other hand, other COVID patients have developed autoantibodies to other self-antigens. There have been patients who have become ANA positive after COVID-19 infection, patients who have become antiphospholipid antibody positive after COVID infection. And then again, even if this is a true causal relationship, does this represent direct viral infection of the tissue? We know that SARS-CoV-2 has a tropism for neural tissue to some extent. Or is this a sterile immune response? We don't know. Still an open question. The only thing I'll add is that if you do see one of these patients, based on the recovery trial from the United Kingdom, Most of the neuro-ophthalmologists that I know have been treating these patients with dexamethasone rather than intravenous methylprednisolone, which is usually the standard of care, but that's a minor point. Other visual pathway diseases, cerebral venous sinus thrombosis. There's been lots of it described with SARS-CoV-2. And again, is that really a surprise? We know that there's this predisposition to venous occlusions. Posterior reversible encephalopathy syndrome. This is fascinating. I'm not a neuro-ophthalmologist, but gosh, there was an epidemic of press in Italy in COVID-19 patients in the intensive care unit. And normally, for those of you who aren't familiar with press, it's usually a disease where it's dysfunction of the occipital lobe, so posterior brain, related usually to uncontrolled hypertension and loss of autoregulation of the cerebral vasculature. But a lot of these patients were hypertensive, the opposite. A number of them were in shock, they were critically ill. So what the relationship is between press and COVID-19, I don't know. Fascinating, still being explored. And of course, acute ischemic stroke. I defer to my other my colleague, esteemed colleague here, but sadly, a lot of ischemic stroke, and that of course can produce a homonymous visual field defects or quadrantenopsias. So I'm going to leave it there because I know I've taken up a lot of time. I will certainly provide. I'm happy to provide all of these slides, and for those who want to read through some of the very rare unfortunate cases of uveitis that have come up within 2 to 4 weeks of the vaccine. You can certainly do that and contact me if you're interested in it. But I just want to thank everyone for the opportunity to speak. And it's always a pleasure to speak to my colleagues back in Kentucky. Thank you.
Thank you very much. That is a lot. I apologize. We did have to cut that short a little bit, but thank you for sharing your slides. I would love to put those up, make them available to people. And in the interest of time, if there are questions, there aren't any questions in the chat. If there are any questions, I would like to hold those at the end. Maybe we could just do all the questions at the end right now. And I will introduce our second speaker. And Timothy, I apologize. I did not ask you how to pronounce your last name.
That's okay. It's Ainger.
Ainger.
Thank you.
Okay, great. Dr. Timothy Ainger is a clinical neuropsychologist and an assistant professor of neurology with the UK College of Medicine and the Kentucky Neuroscience Institute in Lexington, Kentucky. He earned his doctorate in clinical psychology from Gallaudet University in Washington, D.C. He completed his clinical internship focusing on neurocognitive assessment and rehabilitation in veterans with traumatic brain injuries. He focuses on applied neuropsychology, examining ways to enhance the clinical conceptualization of diverse populations and diagnoses. His clinical work and research foci include epilepsy, kidney and liver transplant, multiple sclerosis, resiliency and wellness, primary and secondary changes in executive functioning, psychopathy, and forensics. So any ground that we didn't cover in the first presentation, I'm sure you're well positioned to cover all the rest of the ground. So thank you so much for being with us. Looking forward to hearing from you.
Thank you. Let me share my screen. Typically in neuropsychology, the philosophy is if you specialize in enough things, people can stop asking you general questions. I've not been that lucky yet, but we'll see. I have a lot of information that I want to get through, and I have some pretty pictures and graphs and information we're going to want to look at. Just somebody do me a favor. If my internet drops out, let me know because I'm logged in on a secondary device and I can pick up from there. So I want to talk specifically about the encephalopathic propagation of COVID and sort of what happens after someone develops a COVID infection and how it infects neurocognitively. We'll dabble a little bit in some of the neurological side effects and symptoms as well, but my specialty is in the cognitive manifestation. I want to thank Dr. Sandhu for going first, and really, like, now I'm going to have to step up my vocabulary game. He clearly was showing off that Harvard education with his true, positive, whereas I just say a thing can be two things, but I'll play the game. It's okay. We'll go on. I have no financial disclosures to make. All of my income goes out. I don't make any money off of COVID whatsoever. These are my kids, so it's all, my income goes right to them. I can skip some of the practice gap. This is what we're going to talk about. I'm going to hit the objectives. Let's get right into it. So basically, there's a strong relationship between COVID and the central nervous system. So anytime that someone explains or you're suspecting that they have a COVID diagnosis, you need to move central nervous system to the top of your differentials, because there could be some significant involvement there. The exact mechanism of how COVID-19 enters the CNS is still not clearly established, but there's significant evidence that due to the mechanism of COVID, which I have an infographic on here in a second, we assume that it reaches the CNS via the cribriform plate and the olfactory bulb. In some of the post-mortem neuroimaging studies that we've seen in individuals who have unfortunately succumbed to COVID, we see cerebral inflammation, we see leukoencephalopathy, we see microthrombi, and we see some bleeding phenomena on the brain. In CSF studies from living patients, we rarely find viral RNA in the CSF and in the postmortem brain samples, but we do see specific SARS-CoV-2 antibodies that are detected in those studies. Some other dysfunctional mechanisms in the CNS can include cytokine-driven inflammatory responses, or abnormalities in endothelial cells, damage to the blood-brain barrier, autoimmune manifestations, which we're going to talk about here in a minute, and coagulation disorders. And then in addition, I would be a really bad neuropsychologist if I didn't also mention that there are psychological complications that are compounded by SES factors, long hospital stays, fears of death, et cetera. So all of these things need to sort of be in our differentials as we're managing patients. This is some version of a graphic that most people have seen hundreds of times by now, but assumedly SARS-CoV-2 entering the parenchyma of the brain via the cribriform plate after inhalation. So strong likelihood that the mechanism of infiltration is aerosolized through and then enters through the cribriform plate and then enters the brain from there. That's likely the neurotropic and neuroinvasive mechanism of this. So let's get down to some fun stuff. The neurological manifestation, I'm going to cover a bunch of different very contemporary studies. And just like Dr. Sandhu was alluding to, a lot of this literature has been fast-tracked because we're trying to get it to as many scientists as possible. So we do have to wear our critical consumer hat as we look at this, because some of these things could be kind of spurious correlations or et cetera. But I really tried to narrow this research down to what looks like a strong or a significant group. So this is a study that came out of France with an N of 222 people across several different hospital sites. Slightly more male people in the study, but 30% of the patients by day 6 after their onset of symptomatology were diagnosed with encephalopathy. 26% of patients by day 12 had some form of hemorrhage, usually it was a blockage and a diagnosis of full CVA. 10% at a week out had inflammatory encephalitis, and 7%, which is a little bit strong in this population, were diagnosed with Guillain-Barré. So likelihood for this peripheral nervous and autoimmune inflammatory response. It was more common in this population for those who had severe illnesses, for those who required mechanical ventilation, and also there was some incidents of multi-organ system dysfunction, and white matter changes and punctate microhemorrhages that were seen in CSF or in central nervous system imaging studies. So this is a study where people were observed at bedside, and in this 3,700 N across 133 adult sites, we saw that 82% of patients that were diagnosed with COVID had a neurologic manifestation. At bedside, symptomatology that patients were unaware that they were experiencing but was observed by nursing and care staff was nearly 50% of people had acute encephalopathy, 17% of people were comatose, 6% of people in this population were suffering from stroke, and there was meningitis and encephalitis that occurred in a little bit less than 1%. So similar symptoms, but a different amount of in the population. It was noted in the study that acute encephalopathy is by far the most common symptom that was seen in this clinic. These patients may be in an altered sensory state or have impaired consciousness, or they don't feel like themselves and they act confused, they act delirious, and they act agitated. The general public is not necessarily responsible for knowing how we define acute encephalopathy, but monitoring for an altered state of consciousness, which as a psychologist can also contribute to poor decision-making abilities after acute infection stage. Any pre-existing neurologic condition, any kind, which includes brain or spinal cord disease, chronic migraines, dementia, Alzheimer's, et cetera. Those, based on this study and what we see in situ, are the strongest predictors of developing an ongoing COVID-19 neurologic related complication, to a point where it's actually a twofold risk. The interesting and curious thing about this is there are a lot of people who are unaware that they possess a neurologic disease or a neurologic risk factor because it has not yet been diagnosed. So we talk about risk factors for developing severe complications. Think about the populace of people who don't know that they have diagnosable hypertension, who don't know that they have diagnosable hyperlipidemia, et cetera. So it's a little bit off. I think we're actually slightly underestimating the amount of complexity that pre-existing neurologic conditions can have. This is a study out of Northern Italy where 42.6% of the patients had severe or critical disease, and the overall mortality of the population was 21%. The neurologic symptoms ranged anywhere from dysgeusia and anosmia, which was low in this study, about 10%. But several had post-infection diseases as well, which we'll cover here in just a minute. 30% of this population had at least one neurologic symptom. The respiratory symptoms that were comorbid to this were present in the more severe disease course, which is not unexpected. But it's important to note in this population that the neurologic symptom comorbidity was very heterogeneous. There was no one symptom. The most common one reported was dysgeusia and anosmia. I think that's because they didn't exactly diagnose an altered state of consciousness as encephalopathy. They diagnosed it by symptom, but there's still a lot of heterogeneity. This is a graph representing that population, but I want to get to some prettier pictures here in a minute, so I'm going to skip in the interest of time. In Switzerland, there was a link that was established between obstructive sleep apnea syndromes and the presence of COVID encephalopathy. 91% of the patients that were hospitalized showed an increased gadolinium enhancement on their brain MRI, which was indicative of an underlying endotheliitis. And chronic OSAS related inflammation might be a way that the brain gets exposed to systemic central nervous system injury. So it's proposed that this is a risk factor that is significant for developing downstream neurocognitive difficulties as well. Never mind the fact that sleep apnea is already a risk factor for developing downstream neurocognitive issues. So they propose that if you target OSAS and other sleep apnea syndromes, primarily obstructive, not central sleep apnea, as an actionable item in the recovery process, it may enhance encephalopathic recovery, but when this study was published, they didn't have longitudinal recovery data. As far as psychiatric and neurologic comorbidities, there's frequent neurocognitive sequelae in those that have a more severe infectious route that are long-term complications. Several of these inflammatory markers and vascular concerns seem to be persisting issues. The longer and the more severe that an infection appears to be, the more complicated that the downstream effects are, which is unsurprising, but it is established as a statistically significant finding. Increased stress complicates this as well. Possible increased activation of the hypothalamic pituitary adrenal axis. So as you continuously excite that stress pathway, it can sort of wreak havoc on your central nervous system and on your autoimmune pathways as well. This graph is simply showing patients at a 4-month follow-up that were undergoing cognitive evaluations, and the most severe cognitive deficits were associated with the severity of COVID symptomatology, the breathing, the shortness of breath, and low oxygen saturation. The biggest impairments were seen in verbal learning, verbal memory, executive functioning, and this is very consistent with the literature for post-infectious and post-vascular disease cognitive functioning. So we should start to think about scattered profiles and subcortical findings, not just cortex findings. It's hypothesized from this study that this might be related to low cerebral tissue oxygenation. And it also, on a psychiatric note, low scores on cognitive functioning were also positively correlated to low quality of life in 4-month recovery. So as you discharge patients, be prepared for low quality of life as they go through long-term recovery. Studies have talked about metabolic and cognitive changes. MoCA scores, the caveat with MoCA scores is it's a tool that's used to indicate what requires further investigation. I advise my students not to use a MoCA score as a diagnostic tool, but as an investigatory tool. But in this point in time, we're talking about 80% of patients or greater who were going through a COVID diagnosis had a suboptimal MoCA score with enhancement in that frontoparietal, executive regions, and then those findings were then verified on comprehensive neurocognitive assessment. 66% of the patients in this study also demonstrated that there were aberrant findings on FGG PET study with frontoparietal hypometabolism as well. So that brings up the case of dysexecutive syndrome. And dysexecutive syndrome is what we prominently see in individuals with enhanced findings on frontoparietal circuitry, abstract thinking deficits, problems with disinhibition, difficulty sequencing and planning, slow speed, low mental flexibility, weaker decision-making, all of these things that we attribute to frontal focus, speed, and executive skill. These become across the board weaker and suppressed as there's neuroinflammation and as we continue to see the long-term kind of that COVID long hauler syndrome. So is COVID the linchpin of all these complications? This study looked at COVID healthcare workers who already were functioning at a higher level, 120 workers who had post-COVID diagnoses that contracted while they were teaching people. And they maintained that although these people had a quote unquote normal basic neurologic exam without deficits that were seen on a mini mental status exam, there were still punctate deficits that were seen on comprehensive neurocognitive evals. So they're getting a bit of a false negative when they take an MMSE or a MoCA score. They're still functioning in what would typically be assumed to be an average range, but on a deeper and more complex evaluation, there are problems that we're seeing, especially in mood concerns, but I think a lot of that is due to vicarious trauma influences. But again, visuospatial, executive, verbal fluency, attention, etc. I'm watching the time and I want to get to some good stuff. This is a review study of a massive population that we got of healthcare data, and they just proposed that there's significant evidence for what they're calling substantial psychiatric and comorbid neurologic concerns that include intracranial hemorrhage, ischemic CVAs, Parkinsonism, Guillain-Barré, dementia, and by dementia we don't mean acute, we mean long-term and chronic, encephalitis, mood, anxiety, psychotic, and sleep disorders. I don't have the time to break all of this down, but we can try to make this slide available. I just have to pull a couple things out of the presentation for it. But patients who were experiencing these symptoms, these were the most common symptoms out of that general population. So some of the more significant ones obviously include mood and anxiety disorders, but also there's some psychotic disorder that's present, stroke, Parkinsonism, movement concerns, but also nerve root, and plexus disorders as well. It's just a graphic representation of that data. So I want to bring some case studies to your attention. And these are cases that we've seen in our clinic. So this first one, as you can see, is a 50-year-old female. They were initially treated for a history of intractable focal epilepsy and underwent a left anterior temporal lobectomy. Subsequent to the anterior temporal lobectomy, they had an acute recovery, full remission from seizures, and denied any cognitive concerns. But then 2 or 3 months post-lobectomy, they began experiencing acute changes in mood, affect, cognition, etc. And then it was learned that they were actually diagnosed with COVID-19, and they had some long-term concerns. There was brain fog, sleep paralysis, paresthesias, peripheral neuropathy, but then also the presence of severe psychiatric symptomatology, and it was hypothesized that the virus had an easier access route to the basal ganglia. Reductions in voluntary verbal responses, waxing and waning lucidity, refusal of medications, refusal of food and drink, voluntary urinary retention to the point of complete bladder loss, catatonia, and began experiencing severe religious delusions and actually had to be hospitalized for psychiatric stabilization. The patient is now stable, but because it's hypothesized that there was a little bit of an easier access route because of the recency of brain surgery, that they may have been more vulnerable to complications, especially psychiatric complications. As far as general long-term consequences, it depends on what people are basically reporting to the hospital. So we're doing the best we can to sort of understand it. But the most common post-acute findings are these fatigue and muscle weaknesses, but fatigue can also be brain fatigue as well. Anxiety and depression and sleep difficulties, But sleep difficulties can also be representative of a true neurologic finding, not just that of frustration. So in our second case study, this is a 23-year-old female who had an extremely high level of premorbid functioning. They were a law student who began feeling overwhelmed, lost their attention span. There was no prior diagnosis of ADHD, no indication of any cognitive weaknesses. They were fully independent for their ADLs. And of note, when they came in for a MoCA on their neurology visit, their MoCA score was 28 out of 30. So would have theoretically been written off as a non-neurologic complication by providers who weren't looking for something else. But we saw bilateral basal ganglia hyperintensity, and in the midbrain on T2, the bigger complication was the post-COVID. We later learned that this individual was tested positive for COVID antibodies. The complication and the neurologic infiltration was in sleep circuitry, and they would have weeks and weeks of inability to sleep and rest with multiple medication trials and failures. So one medication would work for about a week and a half and then would fail, and there'd be weeks of sleeplessness. And another medication would work and then fail, and there'd be multiple weeks of sleeplessness. So unsurprisingly, there were significant affective complications secondary to both the acute illness and that progression. And this is sort of I don't expect anybody to read the finer point on the graphs, but take away from the green line, the horizontal green line is that estimated premorbid functioning, and the red line is the clinical threshold for severe impairment. So, or when we're talking about the blue line of where their scores are, you can see that there's a lot of variability that goes up and down across performances, and even some that drift into severe impairment. So there's not only impairment when compared to peer-matched groups, but also impairment when compared to their own premorbid abilities. But this speaks to not only the wide manifestation, because for this individual it was greater in sleep disruption, but also how you need to scrutinize the differences and the problems that the patient may be experiencing relative to themselves versus relative to the general population. Because so many of these scores were sort of within normal limits or below average and wouldn't trigger a finding unless you actually realized that they had a higher premorbid ability. This one has a positive outcome. They were effectively managed. Their immune system is back in check, and they're back in law school, successfully married now. They got married after their infections cleared. One of the last things I want to talk on is this post-COVID, long COVID, longitudinal COVID, whatever it's being called in the literature. In the UK, it was estimated that about 10% of the population have this long-haul COVID encephalopathy. And these symptoms include all kinds of associated things, but it's whatever variables were compounded by premorbid risk factors and the complexity of their acute infection. It's critical from this finding, and it's critical in what we've seen, that all post-COVID management should be multidisciplinary if you're expecting long haul, because of the increased complexity of the presentation that they could have. In Italy, 87% of the patients that were discharged with COVID from acute infection still were experiencing at least one symptom, and 55% of those patients experienced 3 or more of the disease, including neurologic and respiratory symptoms, after months of discharge. So the signs and symptoms of where we begin to sort of classify what is long COVID versus acute recovery is when we start to see it at about 10 to 12 weeks of symptom onset. So they should have cleared from their system by then. And post-COVID is when these symptoms persist beyond 12 weeks of onset. Get to my next. So in an N of 135 multi-center observational study, 13% of the long haul patients had polyneuropathy, 1% with Guillain-Barré, 2% with mild encephalopathy, 1% with Parkinsonism, 1% developed orthostatic hypertension, 1% had ischemic stroke, but 45% of patients had long-term hyposmia or anosmia, despite the fact that they had recovered from the acute illness. Associated psychiatric comorbidities, 11% depression, 25% anxiety, 11% PTSD, but 31% had statistically significant alterations in their quality of life. Here is our case study for a long-hauling COVID patient. This is a 60-year-old male who had high premorbid functioning and education. He was a medical provider and a master electrician. On his initial onset, required consistent assistance and corroboration by family members because he was unclear on how to answer questions, did not understand what mood was, did not understand to respond how he was feeling physically and emotionally. Speech was significant for broken prosody. Initially appeared at the ED, was diagnosed with a mild case of COVID, discharged to home, and 2 months following the acute infectious stage, began experiencing behavioral manifestations that were grossly out of context. The one that stands out to us was they sat down for a family dinner and he took an entire pizza and shoved every slice into his mouth. And when they said, "What are you doing?" he spit them all out on the kitchen table. So that would be an acute altered behavioral manifestation. So when they readmitted, he was initially cleared by psychiatry, screened for seizures. He was seizure negative. The EEG in the background was completely normal. But on the follow-up neurology and neurocognitive consult, we realized there was some psychiatric symptomatology that wasn't popping on all of the tests. And we decided to do some imaging studies in addition to a brief neurocognitive evaluation. So the initial neurocog evaluation, subsequent to these imaging studies, the MRI showed no real significant abnormalities, just to show that this wasn't the unmasking of a pre-existing dementia or Alzheimer's process. So this was negative for any gross structural abnormalities. But the metabolic imaging on the left was taken before we began a treatment regimen, and on the right after we began a treatment regimen. And I don't have the Z-scores up here, but you can see that there is pretty much gross hyper and hypo metabolism scattered across the entire brain parenchyma. There's a lot of lighting up in the basal ganglia, but also across all these other specific cortical and subcortical regions, both hyper and hypo. So I'll explain the treatment plan for this individual in a second after I discuss some of the neurocognitive findings. So the blue was the initial neurocognitive testing that we did at bedside just for learning and memory, and the red was 4 days after treatment. And you can see that there was some improvement. What's important to note is that if you can see my cursor, these three are a little bit of a false negative. This score is less than 55, so it doesn't indicate how bad the initial score was. But there was some delayed recall that it just didn't hit the threshold of above impairment at 4 days. But you can see how scattered the rest of the abilities were. But even after a 5-month follow-up, there was some improvement, but still it was reflective of the initial pattern of impairment, but slightly higher on the scale. So with this patient's treatment management plan was 4 days of intravenous IVIG treatment in hospital. And after day 4 of IVIG, the psychiatric symptoms had completely abated. The movement disorder symptoms had completely abated. He was lucid. He was able to recognize and name members of his care team. There was recall. There was improvement in processing speed. There was improvement in recognition abilities. So we saw all of these things. So then this is the other kind of thing that's been popping recently in the pop media here, is that a lot of long haul patients who then receive a COVID vaccine are reporting to their healthcare providers that their symptoms will continue to abate at a more aggressive rate. And my apologies to Dr. Sandhu for putting up a Yale Medicine article here, but this is just what we found. I'm sorry. And the neuroimmunological thought process behind this is that if you are suffering from a long haul COVID manifestation, it's possible that even after the acute infection clears, it triggers an autoimmune response that forces a continuous cycling of your autoimmune system that can't be turned off. But the vaccination puts a hard stop on the autoimmune process and is able to downregulate the inflammatory responses. So that should be, I apologize for eking over a little bit, but that should be my last slide there. So let me stop sharing. And at this point, I suppose we're happy to field questions.
Wow, thank you. Yeah, that was a lot. I feel like this is an all-day conference in an hour from both of you. There is so much in there. But I would love if people have questions. I know we are a little over, but there's so much in there. So if anybody has a question, feel free to unmute or type it in the chat. And as long as it's not a $100 word, I will try to read it. Go ahead, Mahavir.
Yeah. Thank you, Tim, and thank you, Harpal, for wonderful presentations. And probably I have questions for both of you. In case of eye, blood retinal barrier, and in case of brain, the blood-brain barrier is highly effective defensive system we have. So the question to both of you is, how do virus get into the brain? and how the virus get into the eye if it is not through the, say, conjunctiva. Is there any posterior route there or something? Any one of you can take those questions first.
Mine is a very quick answer. So the mechanism that we believe why we think the cribriform plate and the olfactory bulb are so critical in infiltration is because of the direct access through the nasal cavity and those very fine nerve endings that we have in the cribriform plate, but also the fact that the olfactory bulb has direct connection to the cerebrum and is not filtered through the thalamus and doesn't have a lot of other additional involvement. And because of its primitive nature and primitive mapping across the brain, it's such an easy target for mechanism. Dr. Sandhu?
Yeah. Yeah, great question, Mahavir. You know, it's a particularly incisive question for the posterior segment. There was a big paper out of Germany which showed that they could recover fragments of SARS-CoV-2 virus from the retina, although from postmortem samples, although there are other postmortem samples from other groups where they didn't show that. But it does seem like the virus can get into the retina. If so, how does it go? Is it really like transmigrating through the conj or the cornea posteriorly? Probably not. Probably what's happening is it's going through the systemic circulation when you have a viremia, a SARS-CoV-2 viremia. And in patients with endothelial damage, so those who are basically those who are particularly ill, plus or minus those who are already vasculopaths, like people who may have diabetic retinopathy at baseline and already having competent retinal vasculature that might predispose to entry into the neural tissue of the retina, because there are ACE2 receptors on the retinal ganglion cells and on the retinal endothelium. That's the best guess.
Okay, and probably I'll end it here. My last question is, how we get out of this pandemic mess. Vaccination is not even throughout the globe, and Delta variants, and now we are reading that Lambda variants is also making its way in the Latin American countries. What are the chances that we'll have some sort of therapeutic interventions where we can get out of this, maybe next few months or next year? We don't see any hope because a lot of bad things are happening all around.
The variants, I would say the variants are going to be the death of us, but I hate saying that because it's quite literally true. I'm worried about the susceptibility, even in those who are fully vaccinated. And the great benefit is, even if you're fully vaccinated, depending upon your vaccine, you might experience a less severe course of the virus with a variant, but you're still just as vulnerable to contract the virus in the first place. So the biggest thing that we need to do, in addition to recommending safety measures, social distancing, and using your brain, which is a disease in and of itself in the American population, is as providers, provide psychoeducation whenever possible. So I always take querying whether or not an individual has had COVID and been vaccinated as a part of my biopsychosocial history, so I can see if there's any potential comorbidities, but then giving them the opportunity to ask any questions, clarify and dispel any misinformation that they have received or are reading. Just yesterday, I had a patient who told me they were unsure about getting vaccinated because they read a study in UK where people had gotten the virus and then were not able to get pregnant. And I reminded them that the human gestation period is approximately 9 to 10 months, and there have been no longitudinal studies of anybody getting pregnant since the vaccine's been available in spring that have gone 9 to 10 months. So ever they read that is not a reputable source of information, and also should now consider the vaccine. So trying to be very good about not forcing it down people's throats, but also being very strong in my recommendations and dispelling misinformation whenever we get it.
Yeah.
Thank you.
I think that's an excellent idea. I'm Mahavir, I'm not an expert on anti-infectives, antimicrobials. I do know a thing or two about immunomodulatory therapies. I would say that the evidence on therapeutics to damp down the cytokine release syndrome, or cytokine storm, as it's more colloquially called, there's, we certainly know dexamethasone works, and there's increasing evidence that a single dose of tocilizumab, the IL-6 inhibitor, probably does work as well. So certainly for the sickest patients, I think we're doing much better than we were at the beginning of the pandemic. And we have the monoclonal antibodies as well, the 2 monoclonal antibodies that are FDA approved, at least for emergency use, though that could be a big problem with the variants. The variants may evolve to really not be susceptible to them. So I think on that front, actually, we're doing okay, and we may continue to do better with all of the other immunomodulatory therapies that are being trialed. But yeah, for a true anti-infective, I don't know. Antivirals are hard. Viruses get into cells and then they're not in the bloodstream, and it's difficult. I mean, just look at how there's really only 2 good antivirals, and they're against the herpes viruses, maybe 3, but they're all against herpes viruses, and it's tough. Against RNA viruses, it's hard. And I mean, HIV, I suppose, was another success, but it's very difficult. I don't know. I don't have the expertise to answer that with regard to anti-infectives.
Thank you. Thanks again, Tim and Harpal.
I have my ear to the ground whenever I hear stories of kind of what people are doing in these small pockets that are not effective strategies at all. Most recently, there was a news story about a small community in Missouri, I believe, which is now one of these Delta variant hotspots, where someone in the local underground media had reported that they could prevent COVID not by getting vaccinated, but by purchasing and taking equine deworming medication. So all of the local equine supply stores were now sold out of deworming medication. And I just had a conversation with an ED doc from a rural area in Georgia, where people are refusing the vaccine, but are instead making something called brownie batter, which is an injectable. They're self-injecting, and the 2 key ingredients are methamphetamines and what was the other one? I think it was an oil, like a car oil, and a methamphetamine, and they're injecting it and then being treated in the ED for infections, but thinking that they're COVID clear. So yeah, I'm not one to pick at homeopathic remedies, but I am one to pick at nonsense on the internet for sure.
Okay, thank you so much.
Dave, do you want to ask your question?
Yeah, I had one about the eyes. Do the long haulers tend to have eye problems?
Yeah, great question. And it's actually something at U of L that we're studying in our longitudinal long hauler clinic, basically. As Dr. Ainger was saying, it goes by many different names: post-acute sequelae of COVID, whatever you want to call it. People who are still having symptoms more than 3 months out. It doesn't generally look to be the case, with one possible exception, which is that, and this can happen with other viral diseases, but patients who get a meningoencephalitis, a number of them will have problems focusing at near. So either what we call convergence insufficiency, bringing the eyes together, or just early presbyopia. The way that we all need, those of us who didn't have glasses when we were young, weren't nearsighted, we developed the need for reading glasses, usually in our 40s. That's called presbyopia, and that's just physiologic. We lose the ability to accommodate our natural lenses to be able to accommodate. So premature presbyopia and convergence insufficiency may probably only those who had a meningoencephalitis. Yeah, not most long haulers, but yeah, thank you. Interesting question.
And then I had a question for Timothy too about, do they know the mechanism, how the virus affects all different parts of the brains like that? And is that the same mechanism that other viral infections can cause?
So the mechanism of why it's doing what it's doing is still being studied, but the presentation and the neurocognitive findings are very closely mimicking other autoimmune, encephalopathic, and vascular diseases. So when you think about, if you want to make the brain as simple as possible, there's gray matter, there's white matter, right? So all of the stuff that's done on the outside that would be kind of domain-specific functioning, when you're talking about a syndrome like a dementia or an Alzheimer's syndrome, tends to cluster in one area and affect one specific regional skill. That tends to be more of a cortical insufficiency. When we're talking about vasculature, and as the blood vessels sort of branch farther and far away from the primary vessels across the brain, they branch out into different regions. So when we talk about white matter, subcortical, and infectious profiles, the inefficiencies are kind of punctate and scattered across various regions. So it's not all memory, it's not all, visuospatial, it's a little bit of this, a little bit of this, a little bit of this. The frontal regions, those executive functionings, are so highly susceptible for two reasons. One, they're so diffuse and the frontal lobe is so large, and the specificity of those specific functions across the frontal lobes are still not identified as well as other regions. But two, it's the region that is consistently the most and easiest vulnerable to any type of infection, inflammation, injury, etc. It's not nearly as well neuroprotected as other regions. So that's, I think, why we tend to see a lot more, and it's more highly connected because it's so regulatory for other tasks that we do. So that's why I think we see an overwhelming executive response, but it's scattered across the brain.
Interesting. Thank you.
Mm-hmm.
Our strength is our weakness.
That's right. That's right.
Well, this has been amazing, you all. I am so grateful for you sharing your time with us this evening. And I will be telling everybody about this because it was such a terrific program. There's so much here. If you all have slides that you're going to share with us, I will post those up on our website, and I will post the recording on the website by Friday. So I apologize to those of you who did have trouble getting in. I'm glad you were able to get in here at the end, but I will put the recording up, and I hope that you will take advantage of that when it's there. So thank you all so much again. Thanks for joining us on Bench Talk Live, and hope to see you again in September. Enjoy the rest of your summer.
Thank you. Thanks so much.
Thank you, everyone.
Thank you.
Thanks for the Harvard jokes, Tim.
You're welcome.
Take care, everybody. Thank you.